The following is a paid commercial program. Unless otherwise identified, the guests on the program are employees of the advertiser. Opinions expressed are those of the advertiser and do not necessarily reflect the views and policies of Global News Radio 640 Toronto.
And welcome to the PinPoint House Show. John Scholes here along with Dr. Lou, and we have a special guest on the show today, which is awesome. Love having a guest on the show. It always expands our minds. We learn new things. Dr. Henry Candelaria is here, and from Trillium Health Center, I believe, but you're going to correct me if I'm wrong, Dr. Lou, but Dr. Henry is here to talk about a lot of low back issues, which is, 110% of the population probably suffer from it, so we'll get to that.
Not quite as high, 80%, but very close.
Still pretty high, but I've gave you 80% chance of winning the Lotto Max. You'd go spend $300 on a ticket, right? What else? What's the main theme today, pal?
Yeah, so the main theme is going to be low back pain, which is a lot of what we talk about on the show. And Henry, who's also a good friend of mine and a colleague, is here because he has some specialized work that he does, and he mainly works primarily all in the low back pain sector. So he's a great source and wealth of knowledge for our listeners on low back pain, and we're going to go through everything today from how common it is, what's the most common type of back pain, to how does it get managed, and other approaches that are available. So Henry, I'm going to let you sort of introduce yourself in terms of your credentials, but go for it.
Yeah, I appreciate the time and the opportunity to come and sit and chat with you folks. I know that you've been doing this for a long time.
Yeah.
A lot of really good reviews, and I've listened in myself. To
You
learn
better
a few
have.
things. Exactly.
We're cutting you right now.
I wasn't paid to say that, by the way. So I'm a chiropractor, and I have had the opportunity to participate in as a bit of a different role, the practice lead role with Trillium Health Partners. Out in Mississauga, Halton, Lynn, overseeing the implementation and the operation of a back pain program that's funded by the Ministry of Health. It's been running for about 2 years, going on 2 years. The program itself has been around since 2012. I've had a great opportunity and humbling opportunity, I guess you can say, to participate the way I have in the program. It's a bit of a new role for chiropractors specifically. We tend to try to help patients, guide them through the massive information and options that they have within the community with respect to back pain. It's been successful so far. I think we've seen about 1,700 patient referrals come through the program in that time period. Looking forward to diving deeper.
Yeah, so I mean, and primarily, I guess the program was originally started because of how inundated spine surgeons were with referrals from primary healthcare providers like family doctors, right? Because, I mean, family doctors, their job is to know a lot about a lot of different things, so they don't really specialize in particularly one aspect, right? And back pain, as John was saying, 110 of the population, not so much, but it is about 80% of the population at any given time will experience some type of back pain. And I mean, when you're presenting to your family doctor, and if the family doctor, it's not getting better, then they sort of will think, okay, well, I might as well refer to the spine surgeon. But that creates a big problem because then it essentially backlogs the people who need spine surgery, right? And you get inundated. And I think the stat is, and correct me if I'm wrong, that what was it, like 98% of people that saw a spine surgeon didn't need to see a spine surgeon. So, just if you can elaborate on that, it exists essentially so people like yourself can do the job of sorting through because of the knowledge base that you have, where you're going to be much better in terms of a specific area like low back pain at looking at it and really determining, okay, what am I dealing with here? Is this something that can be treated within the community and within other aspects of healthcare, or does this need to see surgery? And that was where it started.
Yeah, so it was really the brainchild of Dr. Raj Ramprasad at Toronto Western. I think he started working through this around 2008, 2009, and pitching the idea. He's a spine surgeon, world-renowned spine surgeon, expert in the management of back pain conditions, or spinal conditions, I guess you could say. So as you said, he really was the sort of person to really highlight that as a big issue.
Yeah.
you mentioned a couple of numbers. 85% of the population is going to experience back pain at some point in their life.
By 5%.
But it's 85% depending on who you read. But the analogy that I use is if you're a human being on 2 feet on planet Earth, you're going to get back pain at some point, to some degree.
Well, a lot of the research too also looks at that it doesn't really discriminate against like time over the last 100 years. It's not like it's more prevalent today than it was in the early 1900s. And also, like if you're in the third world, you're just as likely to experience back pain. And it's probably because of what you just said is we're on 2 feet and it's a weak point.
You're gonna get it likely. Yeah. It's whether or not you have the resources and access to resources to report it and therefore collect that data point, so to speak. But you're also mentioning again, there's a creates a huge backlog. It's a bit of an enigma. Back pain. It's this sort of benign condition that doesn't result in any lethal outcomes, really.
Most of the time.
Most of the time, yeah, everyone would hope, right? But despite that, it's still one of the highest sources of disability and days lost due to disability around the world.
Yeah.
That and neck pain, as you know, is massive issues that I think, manual therapy and rehab professionals like chiropractors and physiotherapists, who are also frontline people in this program, are well versed and well equipped to help support primary care and the management of those conditions and the patients that come in through the program to be seen for it.
Awesome. So, okay, we got lots to talk about with low back pain for the rest of the show. John, you can take us to commercial and then bring us back.
You bet. You want to reach out. We'll get back to Dr. Henry here. In the meantime, 1-855-55 Lou, DRLOU, info@pinpointhealth.ca to reach out, and on social as well, Instagram and Facebook. There's always great stuff to watch there. So make sure you tune in and check out some of that stuff, and we'll continue with more of the Pinpoint Health Show right here, Global News Radio. And right back to the Pinpoint Health Show. Thank you for tuning in today. Dr. Henry Candelaria is here. We're talking about low back. It's something I think you guys said 85% of people suffer from at some point of their life, varying degrees. So it's a big issue, always has been, probably always will be, unless we go back down to 4 legs, which would probably be a complete regression in evolution. So we're not looking forward to that.
Not for some of us.
Maybe not.
It might be an improvement for some.
That's right, exactly. Anyway, go ahead, guys. Keep going.
Yeah, I think we started with a lot of great things there in terms of why this, the role that you're in and the knowledge, how you've been able to gain a lot of your expertise around low back pain. So I think let's focus a lot essentially on low back pain for the listeners who are suffering from it, because we ended the last segment with you saying something that I thought was really important. It's sort of this benign condition that you go to most doctors or whatever, and you tell them, I've got low back pain, and their diagnosis is, you have low back pain. And it's sort of like there's nothing else that way, right? You don't go in saying, I have a fever, and it's like, you have a fever. There's your diagnosis. It's sort of, well, what's causing that fever? So I think that's a big thing around back pain is really, it's a symptom and a sign that you can look for, and people have it. But there's causes of back pain. And then I guess there's accepted classifications that we have in terms of what the most common is and the other things that lead to that type of back pain. And before we get into that, I thought another interesting thing is because it's this like benign thing, it doesn't get all the attention that more sinister things like heart and stroke gets huge attention, which it should. But what you said in terms of the leading cause of disability, right? It's insane what it does to us from an economic perspective and from a quality of life perspective, because it's not necessarily something that affects the quantity of our lives, because you can have back pain and live into your 90s. And so it's like not sexy in that way that it's like, oh, but this could kill you. But in terms of how it affects our quality, it's incredible. And the disability aspect of it is huge. And so I think it's sort of, and that's maybe part of the reason why it doesn't get the attention it deserves. I think it's starting to get more attention because people are starting to realize, the burden on the system with this. But so I guess before we get into the classifications, do you agree with that? Like in terms of it not being that sexy disease or syndrome or disorder that's going to get all the hype?
Absolutely. I think, there's you hit the nail on the head in terms of the quality of life, quantity of life piece. Yeah. It's not going to shorten your life. but it will impede and impact significantly your quality of life, your ability to engage with the people who you want to engage with, your family, friends.
Yeah.
And people, I mean, you've seen it, I've seen it, people in tears.
Oh, it's ruined lives.
Because of the pain,
Yeah.
one, but also because of the impact that it has on them. They know that it's not a lethal thing, but it is this constant nag, like it's a toothache in your back, oftentimes associated with debilitating leg-related symptoms.
Yeah.
That can have a significant impact on a person's ability to live the life.
I mean, I've seen people that have come in and have said, like, I'm here, and if you can't do anything about this, I'm not even sure I want to live anymore. So even though it doesn't affect the quantity, it can, right? Because, I mean, even if we use the example of, like, spinal stenosis in the elderly, it takes away their ability to move around and walk, which affects their cardiovascular system. So who knows? Maybe it does contribute to less longevity, perhaps. But definitely, I'd say in general, like 95%, it's really about, it's like that analogy of a toothache in your back is perfect, where you just have this thing and it's affecting everything that you do. I'm going through an issue right now where my low back's been a little bit flared up, and it's like I have a 1-year-old at home and my wife's asking me, and it's like, instead of being happy to want to go grab him, the first thing I'm thinking is like, oh my God, it makes my back hurt, right? So that's the constant nag aspect. So can you walk us through the classifications in terms of like what the more common type of back pain is, and then some of the other things? Because I mean, some things can be sinister, but they're very, very rare.
Yeah, that's where it becomes important to see a regulated health professional to get properly evaluated for what the back pain is. And generally speaking, you hit it on the head again. About 95% of cases are mechanical. They're classified as mechanical back pain. It's sort of this generalized blanket term that covers most of the conditions that people present with when they present with back pain, and the types of back pain that they experience. It's usually mechanical in the sense that there's a mechanical source. There's something that is occurring with movement or with load in the spine that results in pain.
Yeah, it's due to the structures that exist.
You got it, yeah.
The facet joints, the muscles, perhaps. It's hard to sometimes, I guess, distinguish what's what.
That's right.
But it's definitely, I think that's an important aspect, because one thing around low back pain is, I mean, the people that I see, I think people are more hypersensitive and they're hypochondriacs a little bit more. So everybody wants an MRI, and we'll get into MRIs because they just want to make sure they're not dying. Yeah. But what you said, that stat is incredible, right? 95%.
Yeah, it's like 90 cases. Again, depending on who you're
depending on
95,
who you're reading, 90 to 95.
Yeah,
but I mean, so the odds would be
likely
that
mechanical.
you're likely dealing with mechanical. Okay, so, and sorry to interrupt you.
Yeah, no worries. So usually mechanical type of presentation, usually benign in that sense in terms of the significance of the back. Again, I use that word significance loosely because I'm not the one that's feeling the patient's back pain. The patient is, right? And so you don't really, you get context, but in terms of the bigger piece being their quality of life thing. And again, the regulated health professional piece to get evaluated appropriately first, your family doctor, nurse practitioner, a chiropractor, physiotherapist, something like that, who has expertise in working a patient up with respect to what is happening with their back. And the important piece to rule out other sinister sources, as you said. You want to evaluate them for things like what's called red flags and those kinds of things. Make sure that those things are ruled out, and then get them appropriately evaluated and determine what might be the most appropriate path for their treatment. So mechanical back pain is usually the most common thing. There's other elements of other types of back pain, including something that's called inflammatory back pain. And let's get to that, because I think we need to take a break, and we'll deal with the inflammatory back pain when we get back from the break. Absolutely.
You bet. It's 1-855-55 Dr. Lou, DRLOU, and info@pinpointhealth.ca. It's the Pinpoint Health Show right here, Global News Radio.
The following is a paid commercial program. Unless otherwise identified, the guests on the program are employees of the advertiser. Opinions expressed are those of the advertiser and do not necessarily reflect the views and policies of Global News Radio 640 Toronto.
And right back into it, the Pinpoint Health Show, reaching out 1-855-55 Dr. Lou, DRLOU. That's the phone number. Go online to Pinpoint Health. You can search that on Instagram and Facebook. There's always fantastic videos and lots of stuff to learn online. It's good to have not only the radio show where you can hear what we talk about, but combine that with the visual component, and it makes even so much more sense. Dr. Henry Candelaria is here. We're talking about low back, guys. And this issue doesn't seem to be going away, but it's a good job you're doing so far of breaking down what it is, right?
Yeah, no, Henry's been an awesome resource here. So we finished talking about the mechanical aspect, which again, depending on what we're looking at, 90 to 95% of low back pain cases. Then you were about to get into the inflammatory back pain, which I think is important for people to understand, because most people come in and they think that inflammation is part of everything, right? Like, do you not see that where they're like, oh, I've been taking an anti-inflammatory because someone told me I have inflammation. But when you and I as healthcare professionals talk about inflammatory spine-related pain, that's a very different thing. So take us through inflammatory spine pain.
Yeah, so to start off, it usually impacts people in earlier on in their life, less than the age of 45 or 50. And it makes up, there's about, I think it's about, if I remember correctly, about 14 to 16% of cases
of people with low back pain.
People with present with back pain present as inflammatory back pain. The challenge with that condition is because mechanical back pain is so common, inflammatory back pain sometimes it presents very similarly. Usually in younger patients, practitioners tend to have a bias towards the mechanical diagnosis. And there, as a result of that, there's a significant delay in diagnosis. So you're looking at 7 to 10 years of delay in diagnosis and people dealing with back pain, this recurrent gnawing discomfort. And that's where, again, this evaluation by a trained, regulated health professional helps, who can ask you the right questions, take you through the right steps to get evaluated appropriately for that type of presentation.
In terms of, because again, we're using, you and I know what's under the list of inflammatory spine pain, right? But the listeners are like, well, what does that even mean? But so some examples, can you walk, like ankylosing spondylitis? Yeah,
ankylosing spondylitis is probably the biggest one. Yeah. And that's one of the common things that we screen for, and I screen for, you screen for as part of your regular workup for patients. There's a series of questions that you ask as part of your screening process and history taking process. And depending on how they score with that, they may require further workup through things like blood work, imaging, x-rays, and those kinds of things to screen for, if you're suspecting it, to screen for inflammatory type of presentation.
Yeah, and so ankylosing spondylitis, and I mean other things like rheumatoid arthritis and reactive arthritis and a whole bunch of, there's even, you can have non-radiographic spondylarthropathy, which is sort of like it's not evident on x-ray, but there might be other indicators. The big thing here for the listener to understand is that this is a degenerative process due to the immune system attacking itself. So it's typically an autoimmune type of syndrome where your body's immune system becomes heightened and all of a sudden it starts to attack the joints itself. The other big thing, which because it's an autoimmune thing, one of the things that you and I would both screen for is other types of autoimmune problems, specifically eye issues, any type of gut issue and skin issue, because when you have an autoimmune condition, it can typically attack more than one body system.
You got it. Yeah. And there's sometimes people present with difficulty seeing, difficulty in painful urination, as awkward as that might be to talk about.
No, it's not. People talk about all kinds of weird things on the show, so go for it.
Heel pain as well. So there's oftentimes a pattern of presentation that if a person is trained, that they can pick up on certain things that would cue the practitioner to initiate a different step, and that may include things like blood work, imaging, and then depending on what comes of those tests, they may be escalated to further care, including, let's see, a rheumatologist or what's called an ACPAC practitioner, which is a subspecialty physiotherapists and chiropractors are trained in as a means of managing and supporting the patient in how they can move and train and exercise to rehabilitate and to maintain what they have, despite the fact that they may have that diagnosis of inflammatory pain. But usually managed via rheumatology, sometimes medications, in conjunction with family doctors and as I said, manual therapists and rehabilitation professionals.
And this brings back to your point, the key on why you should be seen by a professional, right? This is why, you're Portuguese descent, I'm Italian descent, but we both have the same thing that happens, right? Where our family members, oh yeah, but I talked to so-and-so and they had this and it just ended up being this, and they used the soap bar as a form of treatment and there's like some magical cure or whatever. And so I think that's the important thing that I consistently will talk about on this show is that when you're leaving the diagnosis up to yourself, you're probably wrong, and if you're wrong, your treatment's going to be wrong because treatment is predicated by the right diagnosis. So, and that's an important thing. And then what we just spoke about there between mechanical and inflammatory, we're almost dealing with 99% of low back pain that we would see, and then less than probably 1%, maybe slightly higher, is going to be even more sinister things like primary tumors or secondary tumors, which are very, very rare. So, I mean, yeah, this has been, it's great having you here. For the listeners, stick around. We're not done speaking about low back pain. We're going to keep going further into this and probably get into its diagnosis. How, a big thing being is people always want imaging. So I think we'll come back and we'll talk about how important is X-ray or MRI for spine-related pain.
And stick around, do so. Dr. Henry will be here for the duration. This has probably piqued your interest in some way, shape, or form if you're part of the 85% that suffer from low back pain and low back aggravation. Reaching out to carry on, 1-855-55-Dr. Lou, DRLOU. And don't forget PinPoint Health or info at pinpointhealth.ca to reach out through email as well. It's a PinPoint Health Show. It's right here on Global News Radio.
The following is a paid commercial program. Unless otherwise identified, the guests on the program are employees of the advertiser. Opinions expressed are those of the advertiser and do not necessarily reflect the views and policies of Global News Radio 640 Toronto.
And back to the PinPoint Health Show. Dr. Lou is here with special guest Dr. Henry Candelaria, and we're talking low back. You want to reach out, get a hold of Dr. Lou, 1-855-55-Dr. Lou, DRLU is the way. Let's talk about more back pain, guys.
Yeah, so I mean, we ended off the last segment where Henry, I keep calling you Henry because he's a friend, but he is a doctor, and he can call me Lou. You know, that's fine. Anyone can, even you, John, even though you never do.
You guys are so cute. Get on with
it. But so you've walked us in the last segment through inflammatory spine pain. We sort of ended off saying that very rarely you might get more sinister things like primary tumors and things like that. I don't even know if it's worth going into because of how rare it is. If you think it's a valuable insight for the listener, then take us through some of the most sinister things, which, again, let's preface it by saying how rare it is because we'll freak everybody out otherwise.
That's right. Yeah, so there's, again, it comes down to before we ended off the last segment, we talked about how to evaluate and diagnose this thing. And it really comes down to doing a solid history, like take your time to ask patients the proper questions, and they'll guide you and tell you as a practitioner what the condition is. If you just sit down and listen, and you guide them, patients, everybody has their story to tell, and I try to encourage and guide the questioning and their discussion around things that I'm trying to look for. And again, the piece about red flags, trying to rule out sinister types of things by asking specific pointed questions, things like
walk us through some of those red flags so that people know if you're experiencing back pain and also maybe have whatever else, that there's some sense of urgency.
So there's a collection of signs and symptoms usually, and it comes down to things like, if a person has developed recent flu-ish type symptoms, fever or chills, unexplained weight loss in a short period of time. This one isn't technically one, but anecdotally I've used it, a change or loss of appetite or an aversion to foods that you would previously enjoy. Night pain, so pain that wakes you up overnight. You're laying still, and then you have this sort of gnawing pain in the back that wakes you up. We talked about unexplained weight loss as well. Recent bacterial infection can be one thing that may manifest itself if the person is immune compromised or something like that as back pain, more of a sinister type of like an infection of some sort of the spine. Those are the things that you really look for. In addition to that, you look for things like, and this isn't an exhaustive list, full disclosure. But neurological compromise and
that gets into the physical exam, which you or I would do.
We get into that, and then you ask about things like changes or loss of bowel or bladder control, specifically.
Big one.
If you've had fecal incontinence, again, not the most pleasant topic to discuss, but
important.
And then urinary retention with overflow incontinence is what the specific
those
is.
Ones are particularly trying to identify Cauda-Equina syndrome, which is an emergency, right? Like if you have that, that's go to the emergency room. That's not, I'll wait a couple weeks to see my family doctor. I'll wait till tomorrow morning to go to an urgent care clinic.
If you start losing control of your
bowel and bladder, then that's... With low back pain, or in any sense.
You present yourself to the emerge if it's different and new for you. I mean, incontinence and stress incontinence, leakage, that's one thing, but this is different. You can't initiate urination. All of a sudden you're having a conversation or doing something around the house and you go and you don't even know it's happening.
This would be new. Like it would be something that sort of goes along with the presentation of some acute or maybe subacute type of low back pain.
You got it. And in addition to that, what's called saddle paresthesia, or numbness in the perianal area or the inner thighs in the pelvic region. And the question that I usually ask people is, if you go to the bathroom and you have a bowel movement, however you clean yourself, do you still feel everything as you would normally? And depending on how that question comes, then that leads you to different types of pathways of care or questioning or evaluation. So those really cover off the more sinister types of things. Again, not an exhaustive list by any means, but those are the things that we usually kind of touch on to try to check off that box of more sinister sources of back pain.
But it does highlight again, so here's the big thing, because you started by one thing saying about flu-like symptoms. You know how many people are out there right now that have flu and low back pain? This is where, again, going back to having a professional check you out, because it's more about the consistency of that symptom without other explained things, where it's not just about your flu-like symptoms, but maybe if you continue to have flu-like symptoms that don't get better, and you have some new back pain that wakes you up at night, you've lost weight, it's building. When I teach my students, each one is a red flag, but what you're really trying to build is if the patient is a red flag overall, because any one in isolation can mean very little. It's really about painting a picture, which again should not be left up to you, the person suffering with back pain. That's the reason why professionals exist. And I think another thing that I think you and I should bring up is how well equipped we talked about chiropractors and physiotherapists are to assess these things, and if need be, get you to the right place. And a lot of people do the opposite thing here in Ontario, is they present first family doctor walk-in clinic, where really I think there's probably more of an advantage to go to some of these other specialists, primarily because we're specialized in these areas. And that's not to say that a family physician would not be well equipped to rule out these things, but in terms of access to care, right, there might be longer wait times, and it's probably one of the reasons that discourages people from ever getting checked, because they're sitting there thinking, well, I can't get in to see my family doctor for 3 months anyway, so I'm gonna deal with this, I'm gonna live with it. But I think it's important for people to know there's other professionals out there that can do potentially better, but equally as good of a job at looking at these things and identifying where in that spectrum of back pain you exist.
I agree with you wholeheartedly. I think the important piece. The important piece, I think, just to finish off this segment, is, we're all equally trained in the sense of managing and evaluating back pain in terms of the foundation. If you look at online, there's this thing called the Core Back Tool.
That's right.
It's put out by the Center for, the name of it escapes me now, but it's a University of Health Network, a U of T affiliated conglomerate that puts together best practices and practice guidelines and those types of things. And they've put together this tool that essentially sets the foundation for how a patient should be managed and evaluated. So if you stick with that as a practitioner, whatever your stripe, then you're doing the patient a pretty good service.
Great stuff.
We'll take a short break, guys. Get right back at it. There's more ways to reach out rather than just listening. If you want to contact Dr. Lou, do so 1-855-55-Dr. Lou, DRLOU, and online to pinpointhealth.ca. It's the Pinpoint Health Show. This is Global News Radio. And the Pinpoint Health Show continues, reaching out to 1-855-55-Dr. Lou. You want to go to Pinpoint Health on social media as well, like Instagram and Facebook. Lots of stuff to be learned there as well. Guys, want to, as we continue here with Dr. Henry Candelaria, talking about lower back is the focus of the show this week. Imaging and stuff like that. What do you say about that?
Yeah, so that's an important thing that we definitely want to touch on. We've sort of spent a lot of the show right now talking about the different types of back pain. And this is the aspect where, for that 90%, 95% of mechanical issues that present in back pain, this is probably where imaging is not providing the valuation, and an assessment is going to be much better. But then when we're dealing with inflammatory and potentially sinister things like infection or some type of cancer, that's where imaging becomes important. So because the problem here is that everybody wants an MRI of their spine, and it's creating a massive debt on the system, because we can't possibly give everybody that has spine pain an MRI. But even more than if we could do it, we should follow best practices. And if there's no benefit to doing that, then all we're doing is delaying things, and we're just creating a backlog, and it's just a mess. So take us through the imaging piece.
Yeah, so again, the history would lead your diagnosis. You already have it essentially at the end of your history. You should have a list, at least, a differential list.
The practitioner, not
the practitioner.
Yeah, that's right. Yeah.
And then from there, you lead into your physical exam. You go through a standard set of exams to evaluate further and try to confirm or refute what you're thinking may be happening. And then as a result of that, then you come up with a pretty solid idea. And if there's concerns in terms of, as I mentioned previously, this idea of if there's red flags that are there, if they're concerning signs and symptoms, changes in neurology, in terms of the evaluation, once you get those exam findings, it may lead the practitioner to think about ordering a picture. And various different types. The big piece that people always want is this MRI because it gives. Don't you want to see what's happening in my back? And it gives the diagnosis. Well, no. I mean, I have the diagnosis. I use that as a means of preparing for the next step if you need it. If we're going to suggest that you need to see a different kind of specialist that does stuff internally, like a surgeon or an interventionalist or something like that, they need to know what they're getting themselves into. And MRI is beautiful for that because it gives really good detail in terms of the anatomy. And if you have that's really, and again, in the absence of red flags, that's really the only instance where you would need an MRI. The challenging piece is, the struggle for primary care providers is they're under a lot of pressure to perform and to see a ton of people. They're very busy, exhausting days. And they are oftentimes, unfortunately, pressured to put these orders through.
From the patients.
That can get a bit sticky for them. And so it becomes unfortunately sometimes people are cornered into doing it. Sometimes things are ordered when they maybe shouldn't have been. Part of the program that we're running is designed to help a primary care provider determine if the patient in fact needs that kind of advanced imaging.
Right.
And again, to better direct them and to educate them and support them in that decision making. In terms of what comes after the MRI is done, it's a piece of paper with a report on it that can be scary, the scariest thing you'll ever read.
Even the normal stuff is scary.
Exactly. And a lot of the things that you hit the nail on the head again, a lot of the things that are listed there are considered quote unquote normal process of living in a life on planet Earth.
Normal wear and tear. You
got it. And the most important thing is to give that report, and most importantly the pictures, context. So when I see a patient, you got to correlate the findings with the patient presentation. The challenging piece,
preaching to the choir, brother. Yeah. That's what I talk about every week.
Exactly. The radiologist is there, and they're not seeing the patient. They're seeing the picture, and they're reading everything that's on the picture as they need to do. And then it's up to the practitioners who have requested that image to give that picture context. But the challenging piece is that image or the report itself can be quite scary to patients because the context isn't there. So they get the report, they read through all of this scary stuff that's there, the language that's used, degenerative disc disease and arthritis and all this. Yeah. Context is very important.
Sure.
And that's where, again, regulated trained health professionals can give that context. I rely on the report to some degree, but I've relied more on, I ask the patient to bring pictures with them. So bring the disc, let me see the images myself.
Yeah, for sure.
To make sure that I can give context as to what I'm thinking is happening with the patient to the patient and try to frame the report that they have in their hand more appropriately.
Yeah, I mean that's a huge aspect, and I've done continuing education for family physicians where they primarily wanted me to go through what's important and not important on low back MRIs for that very reason, because even sometimes the healthcare professionals who aren't experts in this area, it can all sound very, degenerative disc disease, facet arthrosis, bulging disc at, L5S1. But again, the important aspect here is its correlation with what is presenting clinically. That is the most important. I mean, and the best healthcare professionals that I know, whether they're chiropractors, surgeons, you and I know some of the same surgeons, they will always say that the history, that art of investigating through words and then investigating through a clinical exam is often superior to any imaging. The imaging is just really to confirm what we're already thinking. And like you said, if there's going to be something done internally, it's important to know what you're getting yourself into. But I think the overall message here being that for the vast majority of spine-related pain, it actually provides no benefit. And when you're I've had people where I say, if all you're doing is worrying about why, right? Like, well, what is it? Like, tell me, give me the picture to show me. All you're doing is not spending the energy towards getting better. And that's a big thing. So I would encourage people, if you're suffering with low back pain and all you're thinking about an MRI, you should probably stop and think about getting the right treatment. And in the next segment, we're going to go into treatment of spine-related complaints.
We'll get to that, guys. Want to take a short break here, reaching out 1-855-55-Dr. Lou, DRLOU, and info@pinpointhealth.ca. It's a Pinpoint Health Show. This is Global News Radio.
The following is a paid commercial program. Unless otherwise identified, the guests on the program are employees of the advertiser. Opinions expressed are those of the advertiser and do not necessarily reflect the views and policies of Global News Radio 640 Toronto.
And welcome back to the Pinpoint Health Show. Dr. Lou is here, of course, and guest Dr. Henry Candelaria is here. Guys, we've talked about all of the different facets of back pain. Want to move on to the one everyone's been waiting for. Talk about treatment.
Yes, sir. Henry? I'm just sending it to you, brother. It's all you, man.
What do you do?
Yeah, what do you do?
So, I mean, you've gone through that whole process of working the person up, and there's a number of different lines of treatment that, and again, this is all full disclosure. Again, this is just context.
We've only got an hour. We could probably do
we go on for like 3 days.
Yeah, we could do it
or more, probably.
Yeah, exactly, a whole year.
Actually, 4 years.
Yeah,
4 years.
exactly.
Yeah. So, again, treatment has a number of different aspects to it, and it starts off including things like pharmacotherapy, so medication, and to help you manage with the symptoms that you may have. That usually comes from a nurse practitioner or family doctor. And then in addition to that, especially in the acute stages in the first couple of weeks of having a flare, that's super important. Usually to help calm down the fire, so to speak, as I usually put it. And then once the fire comes down and you have more ambers, then you can start to engage into manual therapy and rehabilitation. Some would argue that you can start off in manual therapy and rehab right off the hop, and there are even pain modalities that are used in those short those early days, so to speak, and that's completely appropriate. The only caveat that, we've had discussions on this, you and I, Lou, and the caveat and concern with that is that people sometimes become dependent on that, or the focus bemes strictly on those passive modalities in the long term.
Yes, 100%.
People get stuck in this cycle.
And medication is a passive modality too, right? Yeah.
So, and that's important to sort of, be in regular communication with the person, with your prescriber, to let them know that how things are going and how the medication may be impacting you, and also the person who you're seeing for manual therapy and rehabilitation, a physiotherapist, chiropractor. Those types of practitioners that can help guide the quote-unquote conservative approach to this, including manual therapy and rehab. And manual therapy meaning it's a massive umbrella term.
Yeah, everything.
A whole bunch of professionals fall under that term. I've only mentioned two, but those types of interventions include things like hands-on manual care, manipulation, mobilization of soft tissues, spine, that kind of thing. And in addition to that, there's acupuncture techniques that are oftentimes used to help abate the pain or help the patient manage the pain in conjunction with that. And it's often used. There's usually rarely one sort of silver bullet. It's usually a combination of things that is used to help the patient manage as part of their rehab. In addition to that, the most important piece is empowering and engaging the patient in an active self-management program. So getting the person active and moving to their tolerance within reason. Obviously, given the diagnosis that you have, you're going to guide your intervention to be specific to that patient's presentation. Again, to your point, a specific diagnosis, history, physical exam oftentimes can lead you to a specific diagnosis, which then can lead you to specific intervention and hopefully the specific and anticipated outcomes that you're looking for, which is return to function.
Yeah.
So those are conservative elements.
And again, quickly, how about like injections and surgery?
Yeah, so that's conservative, and that's, again, not an exhaustive list, but those are just to give people an idea. In terms of if there are other things that require more intervention, depending on how the person presents, etc., then other options are oftentimes or can be discussed, including interventional injection type therapy, usually under fluoroscopic or guidance, imaging guidance, live X-ray or ultrasound for that matter. And that's done by a specific subset of specialists, interventional physiatrists, neurointerventional radiologists usually take on that role. And then again, depending on how the person presents and how they're doing conservative with the treatments, that the low level or starting line treatments, sometimes they can be escalated to surgery. And that pathway is also supported through the program that we discussed at the beginning of the show.
Yeah, that's awesome. So, I mean, we're getting close to the end of the show here. first off, before we move on, thank you for everything that you've taken us through. It's incredible. It's always nice it's the stuff I talk about, but it's always nice to get people who are experts in a particular field, and you are the low back pain guy, I would say, for sure. I know that I look to you for advice on things when it comes to this stuff. And it's so prevalent that, I think this has helped a lot of people to sort of, and again, like you said, this is by no means exhaustive because we're trying to go through this massive problem in an hour show. Is there anything you want to finish off with before?
Yeah, first of all, just thank you again for offering the time and the opportunity to come and sit. Again, I listen regularly, and I'm always keen on the topics.
At the beginning, you said sometimes.
Well, I'm warming up to it. So really, if we mentioned a couple of things at the beginning about this program, it was previously called the ISAAC program, ISAEC. It's now called the Low Back Pain Rapid Access Clinic program, and its Ministry of Health has funded it to go across the province. How you access it would be through your family doctor and nurse practitioner referral via the ISAAC website, isaec.org. You can access it that way. There's a couple of drop-down menus that you find for referring a patient in, and essentially the primary care provider has to register for the program and then refer their patient if the patient qualifies for it.
That's awesome. That's all great work. And I mean, even outside of that, PinPoint Health is around for this type of stuff as well, in terms of if you want to get these things, again, you can go direct to these professionals like chiropractors and physiotherapists, and I know all of the ones that work with me at PinPoint Health are well trained in this stuff. So if you're dealing with low back pain, the important thing, I think the overall message, if you're going to take away anything, is get a professional to look at it, because clearly there's a lot here. We could do a bunch of shows on this, so don't trust yourself or the internet to try to come to your own diagnosis, management, and then, trying to get the outcomes that you think you're going to get, and then when they don't happen, don't be too surprised. But that's it for this week, I guess.
Nicely done, guys, and we'll take it from there. You want to reach out, get a hold of Dr. Lou, and follow through. No problem. 1-855-55 is the number, 1-855 Dr. Lou, and there's also info@pinpointhealth.ca. That is the email address. And always check out social media. Great stuff brewing every week from your team, Dr. Lou. You go to PinPoint Health on Instagram or Facebook or your other favorite social media and take advantage of that as well. We'll catch you next time right here on the PinPoint Health Show on Global News Radio.
The preceding was a paid commercial program. Unless otherwise identified, the guests on the program are employees of the advertiser. Opinions expressed are those of the advertiser and do not necessarily reflect the views and policies of Global News Radio 640 Toronto.